Oh, sorry. Welcome back to Call Through Fall. And today we have Dr. Darsh, and he will be presenting two case studies today. He will have an OBGYN case study and a mystery case study so that you guys can follow along and see where you guys go with that. So I'll let him introduce himself.
Yeah, what's up, everyone? To Club Med, thank you so much again for having me on here for round two. The first time was absolutely amazing. So when you guys asked me to come on here, I hit yes right away. But yeah, so I'm Dr. Darsh. I'm a intern at Penn State Hershey. I'm completing my residency in physical medicine and rehab. So it's a 4-year residency. My first year is internal medicine. And then starting next year, I'll do PM&R. Dr. Darsh is my social media name. So if you guys want to go ahead and follow me there, I reply to everybody. And I think the way we're going to format this is I have two cases. The first one's OB-GYN, which is going to be obvious to you, which is why I couldn't keep it a mystery because you'll see pregnancy in the first slide probably. And then the second one is going to be a mystery case where we'll see kind of how you guys formulate your thoughts and stuff. And then after that, if there's time for a Q&A, you guys can delve deep into whatever questions you want to ask me about anything. I'm an open book. And for those of you guys that know me, you guys know that very well, that I try to keep medicine as real as possible. So let me go ahead and share my screen and let's get into it. So
guys, if you have any questions, just remember to just ask them in the chat and I'll be monitoring that as well. So
yeah. All right. So here's my first case presentation. Don't mind the date. So I actually did these presentations as a third year at VCOM in med school. Hence you see all the logos and stuff there. So let's go right into it. So my main goal here is kind of to teach you guys how to think through the SOAP note process. So the SOAP, subjective, objective, assessment, and the plan. And I think as a pre-med and as you go into medical school, your main objective is to really master the first two, the subjective and the objective. So how to get a history, what's pertinent in the history, what kind of questions do you need to ask, and then how to do a proper physical exam. The assessment and plan is kind of tough because that's something you learn just kind of over time. So just bear that in mind if some of the stuff goes over your head. Don't be worried, you're not behind anyone. All right, so let's start here. So history of present illness, all right? So this is me in the hospital. There's a 32-year-old G2P1, so that means somebody who's pregnant twice and has one kid, at 35.5 weeks with twin gestation dated by ultrasound. Okay, so 32-year-old, has twins in her stomach right now that was dated by ultrasound. She's at 35.5 weeks. She was sent from the clinic due to elevated blood pressures starting in the 3rd trimester. The patient complains of headaches as well as seeing dark blurry spots for the past week, right? So right now, just think about what's concerning, what are some things you want to focus on, what are some things you might know if you know any OB-GYN, things that you just need to keep an eye on. So let's delve more into the HPI here, okay? So here's some tips and tricks of things you guys need to learn and that you will learn when you're in med school or when you go on rotations. So G2P1001, okay? This is the way that we quantify and also qualitate pregnancies. So what the G stands for gravida, right? So that means how many times has the woman been pregnant? So 2 pregnancies. And then the P is para, so it's around that. And then there's 4 numbers after it, okay? And the first number after the P is telling you how many full-term babies does she have. The number after that is how many preterm. The 3rd digit would be how many abortions. And then the last digit is how many living. So a great way to remember that is right here. FPAL is what I think of, Florida Power and Light, FPAL. So FPAL. Okay, so it's going to take some practice, and actually when you're in med school, they're going to give you some HPI cases and be like, okay, give me the G's and P's. So you guys will master that over some time. And then the other thing to know when you're an OB-GYN is how many weeks, what determines what week they're in. So a preterm child means that they're born less than 37 weeks. Term is 37 to 40.6. So the 0.6 means 6 days out of the 7. Late term would be 41 to 41.6, and post term is greater than 42 weeks. And why this matters, there's going to be a lot of complications or certain complications that can happen preterm that you might need to do medical management. Term is what's normal. Late term is a little beyond normal. And then post term could mean, hey, the baby's getting a little too big. What kind of complications do we need to watch out for that? So there's different things for different terms here. And the other thing is elevated blood pressure, right? That's the other thing we found out in this HPI. So if you're less than 20 weeks, oh, my computer's a little, okay, there we go. If you're less than 20 weeks, that's chronic hypertension. So if you're found to have your elevated blood pressures and you're pregnant, and you're less than 20 weeks gestation, that means you probably might have had high blood pressure before you were even pregnant. So we call that chronic hypertension. If it's greater than 20 weeks where they found the hypertension, that's now called gestational hypertension. You're hypertensive due to your pregnancy. Okay, so let's delve into her past medical history. So she's got GERD, and that's something common that we can actually see in women, right? So when your belly kind of gets full and distended, right, there's a baby in there, it can kind of push up on the diaphragm and push up on the stomach. And that could lead some acid maybe going into the esophagus. Past surgical history, none. And then we look at family history, both her mother and father had hypertension. Medications, so she's on metoclopramide, which is like an anti-nausea medication. Pantoprazole, this is something called a PPI, a proton pump inhibitor. And this actually treats, right here, GERD. She's on aspirin 81, so baby aspirin, and then she's on prenatals. So this is very important, right? So if you guys know what the one prenatal is, that's very important. Go ahead and think about it, and I'll come back to it in a bit. Allergies, no known drug allergies. And then social history is so important to ask for women who are pregnant, right? To make sure they're not smoking, there's no alcohol use. Those are really the main two, right? That there's no illicit, other illicit drugs like cocaine or things like this, because you will see them no matter what hospital you go to. And then she is sexually active with one partner. She uses condoms. And then what is her OB history? So we know that she's been pregnant twice, and she has one living child. And so SVD stands for spontaneous vaginal delivery, and she had that at 40 weeks and 4 days. And then gynecological history. So what's the difference between OB and GYN, right? So OB deals with the pregnancy. GYN relates to all the like women parts, right? The vagina, the uterus, the cervix, the fallopian tubes, the ovaries, kind of dealing with those kind of things. So she doesn't really have a GYN history. Okay, does anyone know the prenatals? It is folate or folic acid. So the reason you need that is it can prevent neurological deformities from happening. Okay, review a system. So this is something that you kind of go head to toe, and it's more yes or no questions that you ask the patient. So generally, what are some things you want to ask? Do you have fever? Do you have chills? Do you have any weight gain or weight loss, right? These are common questions that we may ask for somebody who can present with cancer. Because in cancer, you may have chills at night, you may have night sweats, you may have a fever, you may have weight loss usually. So in this patient, nothing. HEENT is head, ears, eyes, neck, and throat. So like she said, she has headaches and she has visual disturbances. Cardiovascularly, nothing. So no palpitations, chest, no chest pain. Gastrointestinal, so just heartburn. So for gastrointestinal, you also want to ask nausea, vomiting, diarrhea, or constipation. Genitourinary, so this is, hey, do you have dysuria? Do you have pain when urinating? Do you have urinary incontinence? Is it hard for you to urinate? Things like that. Endocrine, this is kind of a tougher thing to ask. This can do weight gain, thyroid stuff. Do you feel hot? Do you feel cold? Any type of imbalance maybe with the hormones. Musculoskeletal, do you have any joint pain, muscle aches? Negative for that. Psychologically, how is your mental state? She just has anxiety. And then OB-GYN, there's actually 4 cardinal questions. We call it the 4 cardinal questions that we ask. Do you have fetal movement? Do you feel the baby kicking? Do you have contractions? Is there any vaginal bleeding? Or do you see any other type of fluid coming out of your vagina? So she does feel the baby move, and she is having contractions at 35 weeks. No vaginal bleeding, no leakage of fluid. So those are all great things. Okay, so let's think about our problem list. I'll give you guys here about like 10 seconds, kind of just think about what are the problems we need to deal with this patient. So the first one's the hypertension, right? Because she's sent from the clinic to the hospital because of elevated blood pressure. She's also got this headache. She's got scotomata. I can never say it properly. But that's basically seeing like the blurry spots, like the dark spots coming and going. She's also having a twin gestation. So why is like now the question is that a problem? Well, it's not necessarily an issue. It's not like, oh, you shouldn't have twins, but it's something we now need to delve further into to make sure how are the twins positioned? Are both babies in a good health? What type of twin gestation is it? So those are the things we gotta think about. And then lastly, she has anxiety and GERD, right, which is going to be lower on her differentials, not really things that we really want to focus on too much, but we just write them down just to be thorough. Okay, let's look at her vital signs, right? So her weight, she's 61 kilograms. So if you do the math on that, 61 times 2.2, or is that, I don't even know, like probably like 160-ish, 150-ish. Her temperature is fine. Respiration, she's breathing normal. Blood pressure, so we got the blood pressure marking, 153 over 103. So definitely elevated, right? So usual blood pressure we want to see is like below 130 over 80. And then heart rate is 106. So she's a little bit tachycardic, nothing too alarming. And then her oxygen saturation is 98%. So she's breathing well. Okay, physical exam. So generally, we always look generally. So a lot of your attendings when you go to med school and you present will want to know just basically, what does this patient look like? Are they obese? Are they well appearing? Are they disheveled? Are they in acute distress? Are they breathing heavily? So this patient is well appearing and in no acute distress. That's what NAD stands for. Her skin assessment, nothing really abnormal there. It's probably dry and warm. HEENT, again, head, ears, eyes, neck, and throat. NCAT stands for normocephalic atraumatic. So cephalic means head, and it's normal, so normocephalic, and then atraumatic, there's no trauma. EOMI, extraocular motion intact, so she's moving her eyes properly. And then PERLA, pupils are equal, round, and reactive to light, and they accommodate. Cardiovascularly, triple R is great. It means regular rate and rhythm, and she has a normal S1 and S2 heart sound with no murmurs. Her lungs are clear to auscultation bilaterally. That's what CTAB means. Her abdomen, right? So you're gonna push right where kind of baby is. Abdomen soft, non-tender, and she has bowel sounds, so that's good. Her extremities, she has 2+ peripheral edema in her bilateral lower extremities. So what that means is she has leg swelling, and you characterize it by 1+ or 1 all the way up to 4. So 2+ generally, I'm pretty sure means if you push on it, it takes 15 seconds for the skin to kind of come back to surface level. And then neurologically, AAO times 3 means alert and oriented times 3. So essentially there you're asking, do you know your name? Do you know where you are? And do you know the time? If they can answer all those things, they're AAO times 3. And then OB-GYN exam, negative. So this is where you could do an internal exam on a woman. You're also looking at external genitalia. You're looking at the vagina. You're looking at the labial folds. You're looking for any cysts. You're looking for bleeding. You're looking for any pain. And then internally, you'd be looking at the ovaries as well as the cervix. Okay, so let's look at her labs. So what kind of labs do you guys want to get on this patient? I'll let you guys think about it again for about 10 seconds here. So think about the labs. What kind of blood markers do you guys want to check? Because we have concern for hypertension in a pregnant woman.
Sometimes there's a lag between the YouTube video and here, so it takes like a while for them to hear it.
Okay, so one thing we want to check is protein. So is she urinating any protein out, right? So the kidneys pretty much filter everything, and there shouldn't be too much protein getting filtered out of your kidneys. So at 34 weeks, they actually did a check, and she had 216 milligrams of protein. And at 36 weeks, right, so she came in at 35 and 5. She's now hospitalized. 2 days later, she's at 347 milligrams. So 300s are cut off. So if you're greater than 300, that's positive for proteinuria. So we also want to check hematological labs, right? So something like platelet count. So her platelets are 234,000, which is normal. Normal's in between 15 and 45. And I'll definitely explain why we're checking these things. We also want to check renal function in pregnant women. So serum creatinine, usually normal in pregnant women from 0.4 to 0.8. She's right in that sweet spot, 0.64. And then liver function. So we check the AST and the ALT. So these are both enzymes pretty much that can be elevated if people have liver issues. And we can see here she's at 17 and 16, which are both within normal limits. Okay, so radiology, this is very important, right? For OB-GYN, we want to look and do an ultrasound and see, hey, she has twins. What position could they be in? So in ultrasound, right, we look at her and we found this exactly. So if you look at this picture right here, you have baby A and fetus B, right? So if you guys think about what is abnormal here, it's actually that fetus A is in breech position. So what you normally want in when you're pregnant is the fetus to look like this. You want the head pointing towards the vagina so it can come out head first. So this is what you call breech. Fetus A is what you call breech, where the feet are pointing towards. Fetus B is what you call transverse. So I guess fetus B is actually transverse, is actually more parallel this way. Okay. And then we also look at, if they're twins, how many placentas are there and how many sacs are there. So she had 2 placentas and 2 sacs. So it's called dichorionic, diamniotic. Okay. Now, the reason why this is important is how do you get out which baby first, right? So if you try to get the breech out first, imagine this baby going through, what's going to get stuck? The head is going to hit this fetus's head, right? So you want to try to get this fetus out first, the one with the head down, so that the feet can kind of dangle, come on its own, and then you can get this baby out as well. That's if you're doing a vaginal delivery. Okay, so differential diagnoses, right? So she had chronic hypertension, right? Because we diagnosed her after 20 weeks. And we're diagnosing her with something called preeclampsia. So chronic hypertension with superimposed preeclampsia. And so I'll explain what that exactly means, but essentially she has hypertension. She also has protein in her urine greater than 300 milligrams that classifies her as preeclampsia. So another differential we could think is, does she have preeclampsia with severe features? And I'm going to go over what those severe features could be. 3, she could just have chronic hypertension and not even have any type of preeclampsia. She could have just gestational hypertension, where it would be greater than 20 weeks. Oh, I'm sorry. She had chronic hypertension because she was less than 20 weeks. Gestational would be greater than 20 weeks. She also might just have a headache, or something called HELP syndrome, which means hemolysis, elevated liver enzymes, and low platelets. So this is essentially why we check the platelet count, to see if she has low platelets, and we check liver to see if she has elevated liver enzymes. If she had elevated liver enzymes, low platelets, this is a very serious condition where you would have to stabilize the mother right away and do an emergent C-section right there. So assessment and plan. So, okay, we're gonna go ahead and diagnose her with chronic hypertension with superimposed preeclampsia. So what are we gonna do? We're gonna continue to monitor her blood pressure, make sure it doesn't get too high. And then she has an intrauterine pregnancy at 36 weeks with dichorionic, diamniotic twins, right? That's the other thing we're now here worried about. So what are we gonna do? We're actually gonna schedule a C-section at 37 weeks, because 37, like we said in that first 2 slides, 37 weeks is term. So it's a good time to say, okay, we're gonna wait another week. Hopefully your blood pressure doesn't go too high. We're gonna monitor that. And then from there, we're gonna do a C-section because you're showing some features of preeclampsia. And as always, because I'm a DO, I like to throw in an osteopathic assessment. So I look at every patient that I see and I say, what can we do osteopathically to really help this patient? So in her, she might have some lymphatic dysfunction, which you can see in pregnant women. She has leg swelling. So how can we treat that leg swelling for her? Well, in the hospital, you use compression devices, actual devices that kind of squeeze on the leg to get blood flow and the lymph flowing. Other things you can do is also like a pedal pump and thoracic releases, things of that nature. But in the general OB population, in a lot of pregnant women, what you'll actually see is carpal tunnel syndrome of pregnancy. This is something that's very common. I've seen many times when I was on my OB-GYN rotation. And honestly, what you tell them to do is soak their wrists or hands in really like warm water so that the tissue kind of relaxes. And then what you want to do is right where there's carpal tunnel on that on the palmar surface of that wrist, you want to massage laterally where that soft tissue is. And that will actually kind of just release everything, even the ligament, and they'll feel better. But it is a very common issue, so just keep that in mind when you guys go through your OB-GYN rotation. Okay, so let's go to our discussion now about our assessment and plan. So what is preeclampsia with severe features? So it's anything where the hypertension or the blood pressure is greater than 160 systolic or greater than 110 diastolic, which was not the case in our patient, or it's greater than 140 systolic, greater than 90 diastolic with or without proteinuria, which she did have. And you're going to have some sort of either cerebral or visual disturbances. Now, these are the severe features, right? So what did we see in her? She had a headache and she had the scotomata, flashes of light. Or what you can also see in patients with severe features is right upper quadrant pain, right? Because that's where your liver is, or transaminase concentration. So that's like your ALT or AST, greater than 2 times the upper limit of normal. So probably around like 60 or 70 or 80. And she was around 16 and 17. Or another severe feature would be less than 100,000 platelets. She was normal at around 250. Or you could see renal insufficiency. So this is where your serum creatinine would be greater than 1.1. And so we use creatinine as a marker for kidney function. So now you can see why we got all those labs. We got the renal function labs, we got the platelets, we got the enzymes as well. And you can also get pulmonary edema as a severe feature, which she did not have. So before I go to this board question, I did just want to talk about, let me go back to one of the slides here about why we care or what you'll actually see in this. So the reason we're doing a C-section, the other reason why, because we could easily do a spontaneous vaginal delivery with this. But the reason we're doing a C-section is an OB-GYN's not going to work 40 hours straight or 30 hours straight, right? Imagine if a woman's in delivery or in labor for about 24 hours. That OB-GYN is probably going to go home and not be there. And another OB-GYN doctor can come and do the delivery. Now imagine if the first obstetrician was saying, okay, let's do a vaginal delivery and the baby's starting to come out, okay, but then, you know, and then it goes back in. So it can always be unexpected. But then what if that second doctor who comes in is not comfortable with doing a vaginal delivery? What if he's more comfortable doing these types of things C-section? So the way I learned it is to make it easier for everyone, we're just going to do a C-section right away because it takes not a lot of time, you know, honestly, maybe an hour max. And it keeps the doctor safe, it keeps the patient safe, it keeps the baby safe. So that's why we also elected to do a C-section here. All right, now we can go on to the board question. Okay, so a 35-year-old G4P3013 comes to the clinic at 29 weeks gestation complaining of headaches and abdominal pain. She states that these symptoms began about 4 days ago and have been worsening. The patient's vital signs are notable for blood pressure of 142/89. On physical exam, pain is elicited upon palpation of all 4 quadrants, in particular the right upper quadrant. A urine dipstick demonstrates no protein. Lipid profile as well as platelet counts are normal. The patient is admitted to the hospital and started on IV magnesium sulfate and labetalol. What is her diagnosis? So I'll let you guys, here's the option. So I'll let you guys think about what does the G4P3013 mean. Think about her gestation. She's at 29 weeks. Her blood pressure is elevated, right? Right upper quadrant pain. However, platelet counts are normal, lipids normal, proteins normal. And the patient is admitted to the hospital. So I'll let you guys think about this. What do you guys think? So let's go through a HELP syndrome. What is that? So that's hemolysis, elevated liver enzymes, low platelet. So that can't be it. Preeclampsia, okay, so she does have like the elevated blood pressures. Eclampsia, it actually has to do with seizures. So it's preeclampsia, and on top of that, you have seizures. Preeclampsia with severe features, okay, so we kind of went through what those were, and then gestational hypertension, greater than 20 weeks, getting diagnosed with hypertension. So answer is D, right? So she has preeclampsia with the blood pressure, and then what is that severe feature she has? The right upper quadrant pain. So even though her protein's negative, even though all her labs came back fine, because she has that right upper quadrant pain, she would be classified as preeclampsia with severe features. Okay, so things to think about. So why is hypertension bad in pregnancy, right? So what happens when you're hypertensive? Your blood flow gets constricted, right? And so what does that mean? The fetus in your belly can't get as much nutrients or blood that's needed to be. The placenta doesn't get all the nutrients it needs to because of this hypertension. So that's why we modify that and we try to treat that. Vaginal or C-section with twins, I kind of just went over that. So some places will do vaginal, some places will do C-section. It's really up to the discretion of the doctors. And should we always believe the patient's story? So the reason I wrote this, if I go back to why I wrote that 2 months ago, the patient was telling us that she was never diagnosed with hypertension. So you can take that at face value at first, but it's always important to do a chart search and make sure, hey, did this patient have hypertension before she was pregnant or not? And we found out that she was. So that gave us reason to be a little more, safer, because we were like, okay, she already had hypertension. This is not something new. So she was not diagnosed with gestational. She was diagnosed with chronic. So that's the other reason I put that. All right, guys. Well, that's the first case. So a little different. I'm no OB-GYN doc, but hopefully I kind of gave you a little glimpse into the world of that. And then let's go into this one as well. Okay, so I think we're right on time. So I'll let you guys kind of debrief on that, think about it on your own for that whole OB-GYN case. And again, if you have any questions about these cases, you can personally DM me at Dr. Darsh on Instagram. I reply to everyone. So I'd be more than happy to kind of go into these cases or any other questions you guys may have about the field of OB-GYN. All right, so next one, here we go. Oh, this one I got the date right. All righty, so history of present illness. So we have a 74-year-old male who presents to the outpatient clinic with a dry cough for 3 weeks. His dry cough is complicated by shortness of breath on exertion. He's also got intermittent left arm numbness for several years. At his 1 month follow-up, right? So the first 3 bullets are kind of, let's say, time 0. And the next 2 bullets are 1 month follow-up. At 1 month follow-up, his cough is still persistent. He now has new onset bilateral shoulder joint tenderness and bilateral hand joint tenderness, worse in the morning. And then from there, another 6 weeks from the previous visit, his previous complaints are still persisting, but now he has new onset bilateral knee joint pain, low back pain, and dry eyes. And then 1 year from then, he now has a new onset rash on arms, chest, and back. Okay, so a lot to take in there, a lot of issues. We've been following this patient now for about 1.5 years. Okay, so past medical history for this gentleman. So alcohol abuse, he's pre-diabetes, and GERD, right? So acid reflux. Past surgical history, appendectomy, colonoscopy. Family history, mother had coronary artery disease, breast cancer, hypertension, heart failure, hyperlipidemia. Father had heart failure. Medications, omeprazole, again, so that's a proton pump inhibitor. Guys, you will see this on every patient. And if I can urge you guys to do one thing when you guys go into the healthcare field, make sure that these patients actually need it. And if they don't, please take them off these medications, because honestly, we kill so many people, or we create so many side effects due to just giving people medications. So that's just my, please, if that's one thing you guys can do, make sure patients are on medications for a reason, not just because. Allergies, no known drug allergies. And then social history, he would drink 1 to 2 beers a week, does not smoke, he lives alone, and he's retired. So nothing that really points us into kind of his HPI. Okay, so review of systems. So no fever, no chills, no weight gain or weight loss, no visual problems, no ear pain, no congestion, no sore throat, no chest pain, no syncope. He does have a fast heart rate, tachycardia, and he had recent normal cardiac evaluation. So he just had a cardiac evaluation because of that left pain. So they probably looked at his cardiac enzymes, a chest x-ray and EKG, all that came back normal. Chest, shortness of breath, as well as a cough, no nausea, no vomiting, no diarrhea, no gross hematuria, so he's not peeing out any blood, but he is complaining of having trouble urinating. Endocrine, he is having dry eyes. Musculoskeletal, of course, the joint pain and the muscle weakness. And then skin, we know that he has a rash on his arms. So problem list, all right? So you guys go in your head right now and kind of think about what are the problems this gentleman is experiencing? So one, obviously the cough that's been persisting now for a while. His joint pain that went from his shoulders to his wrists to his knees. This new onset rash that just recently started. The dysuria, the arm numbness, and the dry eyes, and the low back pain. Okay, so let's look at his vital signs. So everything looks kind of normal here, besides his saturation of his oxygen. And of course, his heart rate's a little elevated. But you'll often see that for people who come into the doctor's office because they might be nervous or anxious. But 92% is definitely not normal. So we would like to see it above 97% oxygen saturation. So he's at 92. Not terrible, but something where we say, huh, that's pretty low, and it probably is low because of the shortness of breath and the cough. So physical exam, okay, so a lot more on this patient. So generally well-appearing, no acute distress. If you look at his skin, he's got a flat erythematous rash on his chest, arms, and back. Okay, so location is gonna be very important with this. And again, this is a mystery case, so I want you guys to kind of think about all this. HEENT, so normocephalic atraumatic, extraocular movement intact, and he's got normal conjunctiva. So the reason we're looking so much into eyes is seeing because of his dry eye complaint. Cardiovascularly, he's completely normal. His lungs, he's got RALs in the right lung base. He's got no wheezes, non-labored respiration. His abdomen's normal. And then for his musculoskeletal exam, right, because he's got the joint pain and numbness, he's got numbness in the ulnar nerve distribution with forced flexion of the left elbow. So think about like curling your bicep. So that's forced flexion of the left elbow. And then on your pinky side, that's where he's feeling this numbness. He's got negative Phelan signs. So Phelan signs is essentially when you put your hands together in like a prayer symbol and you push. And usually if you have carpal tunnels or something, you can feel numbness or tingling with that. He has decreased range of motion of the bilateral IP joints. So it's the interphalangeal joints of your fingers. And then he's got mild swelling with noted heat. So it's a little warm when you touch it. He's got decreased strength, but he's walking normally. And then neurologically, he's alert and oriented ×3. So labs. Okay, so this gets interesting. This is what do you guys want to get? What are you guys even thinking this guy might have? Right, so let you guys think about it. So normally we get this, the usual BMP, CBC, checking your electrolytes and blood panel. What else can we get on this guy? He's got a complaint of dry eyes, joint pain that's not on one side, but both sides, starting from his shoulders, then to his wrist, then to his knees. So we're thinking autoimmunity here. So HLA-B, so we're gonna just check a bunch of markers that could be for autoimmune. So HLA-B27, there's a bunch of things where it could be that the mnemonic is pair. So it'd be like psoriatic arthritis, ankylosing spondylitis, reactive arthritis. I forget what the inflammatory bowel disease. RF for rheumatic arthritis. So that was negative. ESR is something called the sedimentation rate. So if that's elevated, that just means you have an inflammatory process going on in your body. CRP, kind of the same thing, C-reactive protein. Double-stranded DNA, so this is also very specific for autoimmune disease. Anti-SSA, so here we go, we have a marker that's high. So, and anti-SSB is negative. So what anti-SSA is actually a marker for something called Sjogren's disease. So that's usually where you find dry eyes in those patients. It's classified as like your tear ducts and your saliva kind of get like dried up. Uric acid's negative, right? So why would we check a uric acid? Because of gout. CPK is elevated. Okay, now this is definitely pointing us to something. So CPK is your pretty much creatinine phosphate kinase, I believe. And it's broken down from your muscle. So this is elevated. TSH is normal, so that's something your thyroid stimulating hormone. And then his creatinine is normal. So that's the kidney function. His calcium is normal, CBC is normal, so the white blood count, hematocrit, hemoglobin, things like that. His urinalysis was normal, so we didn't see any blood in there, right? He was complaining of dysuria, so we want to make sure he doesn't have a UTI or something. LFTs, AST was mildly elevated, which we'll probably see with the alcohol picture. So if you remember from our last case, we had an AST and an ALT. In alcoholics, the AST is usually twice as high as the ALT. And that's because of vitamin B6, and one needs it, one doesn't. So that's the reason why. So back here we saw, okay, anti-SSA, that's for Sjogren's, and then with CPK, which that could be kind of a lot of things. So we'll go into that. So radiology-wise, this guy got a bunch of studies. So we did a CT scan of his thorax, and what we found was interstitial lung disease, right? So makes sense. That definitely explains his cough and shortness of breath. So interstitial lung disease, this is where you kind of get fibrosis in your lungs. So imagine like a mesh wire, and that just getting like really rusted and crusty. Imagine this guy's lung looking like that. So it's very hard for oxygen to get diffused across the lung into the blood. Other things noted on the CT scan of the thorax: mild mediastinal adenopathy, mild cardiomegaly, right nephrolithiasis, nothing to really worry about there. And then like I said, he got a complete cardiac evaluation. That was normal. We got an x-ray of his lumbosacral spine, right? Because we want to rule out ankylosing spondylitis. That's where I'll let you guys kind of look these things up because of time, but it was normal. And then the x-ray of the knee and wrist, because we want to rule out rheumatoid arthritis because the interphalangeal joints were swollen, and those were normal as well. And then we did an EGD, which is pretty much just a scope down his mouth, and that was also normal as well. So differential diagnoses. So what do we already think? So this guy definitely is positive for Sjogren's. So we definitely know this guy has Sjogren's. But what can that CPK tell you? It comes from the muscle, right? So this guy probably has an inflammatory process going on in his muscle. So let's go through this. So the first thing is actually called dermatomyositis. So derma, right, the skin, myo, muscle, itis, inflammation. So this is what we're absolutely thinking, because he also had a rash, right? He had a rash on his back, his chest, his arms. And I'll try to pull up some pictures on Google after this to kind of show you guys some of the rashes that you can see in dermatomyositis. And we'll go through and discuss that. The other thing could just be polymyositis. So polymyositis is almost the exact same thing as dermatomyositis without the skin inflammation. So in both of these, the muscles inflamed. So that's why you're seeing that CPK being elevated. Okay, 3, Sjogren's syndrome, right? Because that anti-SSA was high. He also has dry eyes. So the duct and everything are kind of drying out. Something called inclusion body myositis, which you can also see it's a similar picture to polymyositis and dermatomyositis. Maybe he just has dermatitis with the rash. Maybe he has something called sarcoidosis, which is something that could affect the lungs. And it's also could be autoimmune. So assessment and plan. So we're diagnosing this guy with dermatomyositis with superimposed Sjogren's syndrome. So 2 autoimmune diseases that this gentleman probably has. So how do we treat that? We give prednisone. You actually give steroids. And why? Because steroids decrease inflammation. We're also going to refer him to rheumatology. We're going to consider giving him methotrexate, which is a pretty harsh drug, but something that you use in autoimmune patients, and remove the prednisone. We're going to refer to pulmonology for his shortness of breath, his interstitial lung disease. And here we said tapering prednisone exacerbated symptoms. So usually when somebody's on a long course of steroids, you don't want to keep giving steroids. And the reason why is your adrenal glands above your kidneys are actually responsible for secreting these steroids, right? To keep your circadian rhythm and all your hormones in check. But if you give somebody steroids for so long, those adrenals are going to stop working. So if you all of a sudden don't give these patients prednisone, they don't have any cortisol in their body. It's not coming from anywhere because the adrenals don't know yet to give it. So that's why you have to taper these patients. You can get 40 milligrams for a week, then 30 milligrams for a week, then 20, then 10, and so on. So for that reason, you want to taper. But in this patient, when he was getting it tapered, his symptoms came back. So maybe this patient needs to be on a higher dose steroids for a long time in his life. But again, we know that steroids decrease inflammation, but what they also do is decrease your immunity. So steroids are not always the best drug to use. So again, osteopathic assessment, what can we do to help this guy out without any medication? So let's focus on his cough and shortness of breath, right? So he's got interstitial lung disease. So one of those treatments is actually called rib raising. And this is something that you can easily do in pediatric population with kids who have a cough or bronchitis or asthma or things like that. And essentially what you do is they're gonna lay on their back and you're gonna take your fingers and actually go to their back and push up onto their ribs. And you wanna hold your fingers to the medial rib angle and push superior laterally. And the reason I have that wording is because if you go to a DO school, that's very important to know for your board exams, where exactly your fingers go. But you do wanna watch out for contraindications. For instance, if somebody has cancer and somebody like dermatomyositis, if this gentleman did have cancer, you don't really wanna do OMM. That could really increase the lymphatic system and cause metastasis even more. Okay, so as we said, dermatomyositis with superimposed Sjogren's syndrome. So demographics, I want you guys to kind of think of these things. Who usually gets autoimmune diseases? Which gender, which age range? Is this unusual for a 74-year-old gentleman to get an autoimmune disease, especially with no family history? So kind of just think about that. So what about the progression? How does the progression of autoimmunity and especially dermatomyositis come on? Is it insidious? Does it take a while, or does it really acute that boom, it just kind of comes on? What are the skin findings that you'd see on dermatomyositis? And I urge you guys to also Google this if you can right now. If you're on a laptop, definitely just pull up Google Images and type in dermatomyositis and take a look at the rashes that you'll see. And how do we diagnose this, right? At what point can we say like, oh, we've diagnosed my dermatomyositis? How do we diagnose it? And what are the complications that we can see with dermatomyositis or Sjogren's syndrome? All right, so let me go back. So demographics. So autoimmune diseases, we classically think of them in women around the age of 40. So middle-aged women or younger women, 20 to 40s is classically what we think. So if you're ever getting a board question and you see, you know, a rash, like a butterfly rash on the nose, and it's like a 30-year-old woman, you automatically want to think like lupus or something like that. So for this guy, for a gentleman to be 72 and then being diagnosed with autoimmunity, pretty rare. Progression-wise with dermatomyositis, it's pretty quick. This guy went through, what, a year and a half from shortness of breath to all this joint pain, even while being on steroids and stuff. So it can definitely be quicker. Skin findings, hopefully you guys are on Google Images and you guys can kind of see some of the symptoms. Gottron's papule shawl sign. So think about wearing a shawl, right? What does it cover? Cover your chest and also cover your back and shoulders. It's exactly where that guy had those rashes. And then Gottron's papules are like rashes on your fingers. So you can definitely see a lot of different presentations of dermatomyositis. Diagnosis, so the gold standard of diagnosing is actually doing a muscle biopsy. So you want to get a muscle biopsy, look at it under a microscope and see, hey, is there inflammation? There's certain things that you can see to diagnose as polymyositis versus dermatomyositis. And then complications, right? So this guy has interstitial lung disease. That is really serious because this guy now needs oxygen. His interstitial lung disease is going to progress. And honestly, he's probably going to pass away from the interstitial lung disease more than anything else. Okay, so time for a board question. So a 42-year-old man presents to the clinic complaining of increasing difficulty climbing stairs and standing up from sitting in his chair. On exam, you perceive that his strength to be 5 out of 5 distally, but only 3 out of 5 in his proximal muscle groups bilaterally. There's a distinctive rash on his upper eyelids and around his eyes. Examination of the fingers is most likely to reveal which of the following. So things to kind of take out of here, right? So difficulty climbing stairs and proximal muscle groups. If you ever see proximal muscle groups that are affected, you want to think more autoimmune picture. If they're more distal, like your ankles, your calves, your forearm, then you're not really thinking autoimmune picture. But shoulders and hips, those are like the first 2 signs that you'll see. And then you see distinctive rash on his upper eyelids around his eyes. So I'm sure as you guys are on Google Images looking at dermatomyositis, you guys would have seen this heliotrope kind of rash around the eyes. So what would the fingers show? Would they show dactylitis, which is like inflammation of the fingers, enlargement of the PIP joint, ulnar deviation of the fingers, so that means the fingers moving more towards the right side, if your palms are down, would you see violaceous papules over the metacarpal, the PIP, and the DIP joints? So the MCP joint is pretty much where the thumb meets your wrist. The PIP joint is like your first knuckle if you're moving your finger from your wrist to your finger. Excuse me. And the DIP joint is the one next to your fingernail. Or would you see nail pitting with oil spots? So I'll let you guys think about that for a second, knowing what you guys know this is, right? So this guy has dermatomyositis. And again, Google Images have probably, you guys have probably seen some hand images here where the answer should be D, violaceous papules over MCP, PIP, and DIP, exactly what this gentleman had, which would be called Gotron's papules. All right, so let me, wait, oh, there we go.
I saw a question on that case study. Someone asked, do these rashes become ulcers if left untreated?
No, usually they don't, not in dermatomyositis. They usually just stay as like flat erythematous. And the thing is, it's usually where the sun can hit you. So that's why you see it in the chest, on the arms, on the fingers, and not necessarily like on the shoulders or the stomach. It's usually wherever the sun can hit you.
Mm-hmm. So it would be the long-term effect if this wasn't to be treated.
Oh, he would, yeah, he'd probably progress very quickly. And I think he would probably pass away within like next 2-3 years. Especially without those steroids. So it's mainly the complications of dermatomyositis that can get to you. And in this guy, he had really bad interstitial lung disease. So just that fibrosis in his lungs, wouldn't be able to breathe well, would have to be on oxygen very quickly. Yeah.
Yeah, that's crazy. So that was some of the main questions I saw in there. So if we want to transition a little more into what you do and what you see on a typical day, would you be? Yeah. A few minutes. So like on a typical day, what do you do? Because I'm assuming these aren't the typical cases you see on a daily basis.
Absolutely, yeah. These are definitely zebras. But what's interesting is because I'm in my intern year, so like internal medicine, these are potentially cases that I could see for my first year. So because I'm in physical medicine rehab, so during my years 2, 3, and 4, probably won't be seeing these cases, especially the OB-GYN case. But if the gentleman, if he needed to get like rehab or something, I definitely could probably see him because of the muscle weakness. So that's something I could potentially work with him on if he had good long-term prognosis. But typically for me, being an internal medicine resident for the first year would be outpatient and inpatient. So currently I'm on outpatient. So right now I'm dealing with acute kind of injury. So I just saw a 20-year-old with a popped like blood vessel in his eye. I just saw vaginal bleeding. I saw depression. I saw COPD, interstitial lung disease the other day. So you're definitely seeing a variety of things. And then the inpatient side of things depends whether you're like on the ICU, step down unit, or just the general wards. But you can definitely see some like crazy things. Hours wise, I'm looking anywhere from like, if I'm on the wards, probably like 75 to 90 hours a week. And then outpatients are definitely a lot more chill and relaxed, where it's kind of just a 9 to 5 gig. So it definitely varies. When I go to physical medicine rehab, it'll be a lot less hours because your patients are more chronic and there's not so much more acuity, although emergencies can happen. But it is definitely a lot more chill in that sense where you're kind of focused on the patients and getting them through the rehab process.
Someone asked, what's your lifestyle like? I think they're asking because it says I'm assuming it's different than an MD. So maybe if you could talk about how incorporating OMM makes your practice different than a MD would.
Yeah, sure. So I think that a DO's practice, and this is the thing, most DOs don't use OMM. I would say probably like 90% and 95% of DOs do not use OMM. Probably like 5% in my class will actually use it. It's one of those things that either people don't believe in or people just don't find value in it and they don't know how to incorporate it. For me, going to physical medicine rehab, it's like the perfect tool in my toolbox to bring out and use because I'm dealing with the muscle, I'm dealing with ranges of motion, I'm dealing with rehab. But in terms of DO and MD, in terms of lifestyle, they're the exact same. So there's absolutely no difference whatsoever. So the lifestyle really depends on the field. And as a resident, where you're getting trained. There are some programs that are very, very tough and expect you to be there all the time. There's some programs that care about wellness. And luckily I'm at a program that cares about wellness. But I'm also a person that really prioritizes wellness and a balance between my social life, my relationships and work, and just me becoming the best version of myself too. So those are all things that I really care about. So for that reason, I've been practicing, really trying to improve on my work-life balance. So I've been pretty good at it so far.
So someone asked, any advice you wished you knew going into medicine?
Oh my God, I could do like a whole 5-hour talk on this. As some of you guys know who have heard me talk on Instagram, on lives and stuff. One, take a gap year, do gap years like for sure. I think it's the right way to go just because you need that time to develop and mature yourself just mentally. This is no offense to anyone who's 20 to 23, but even me when I was 23 or 24, I don't think I had the mental capacity to go into med school because it's not school anymore. It's your career. You have to treat it like that. Other thing I would say is remember to stay on your own path. It's not worth comparing yourself to anyone or anybody. In the end, you're not going into probably the same specialty. And if you are, you're not going to the same residency. And if you are, you're not going to work in the same city. And if you are, you're not getting married to the same people. And if you are, your kids aren't going to be the same. Your lives are completely different. So treat it differently. Enjoy your journey. Be whatever major you want to be. If I could go back, I would not have done bio, not done a 7-year med program. I would have done econ or business major or something, because I would have taken those skills and put it into my practice right now as a physician, which would really greatly help me. So there's no utility in being a biochem or chem major. None of those things translate into med school. Med school is its own beast, its own animal. So don't think, oh, I have to do a science major in order for me to gain ground. No, do what you love. It's the only time that where you'll take 4 years and go in depth into a subject that you find fascinating, like computer science or philosophy or math or whatever it is. So don't be afraid to switch majors. You can always do a pre-med minor, right? And then what if you find out, hey, medicine's not for me? At least you have another avenue to pursue or something. So I like to keep my options open and kind of just delve and learn a lot of new things. So those are kind of the 3 things. If you want to hear more, definitely direct message me. I have so much more I could say.
So when you're seeing patients every day, what other specialties do you work with closely or refer patients to? Because obviously not every case that you have, like you said, the, OBGYN. So like how
Yeah,
do you,
absolutely. So with internal medicine, you're kind of the general on the field, right? So think about it that way. The internal medicine's on the hill, taking care of the battle right there. But then what if you need someone who's like really good with a rifle, somebody who's really good with a tank, somebody who's a great defender, right? So that's when you start to consult. So if we have somebody who needs like a liver transplant or really has jaundice or something, we're going to call GI and say, hey, we need your help with diagnosing and management. If we see a patient with like really bad thyroid disease, hey, we're going to call endocrine and say, we need you on this. So you're definitely going to work with every single specialty, even surgeons, even all different types of surgeons. And that's no matter what field you go into. So whether you're internal medicine, family medicine, healthcare really is a team-based approach. Physical medicine and rehab, we rely heavily on internal medicine doctors as well as the non-physicians. So physical therapists, occupational therapists, speech therapists. PM&R is a very team-based approach.
mm-hmm. So just overall, just to kind of wrap things up, to someone who might be considering PM&R, why PM&R?
Yeah, so I honestly think it's the best field for, man, a lot of things. One, if you really want to work with motivating patients. So if you really are not somebody who wants a one and done with a patient, but you're someone who wants to take them through their journey of their ups and downs, really hold their hands and be with them side by side for like a month or 2 and really see progress, it's the perfect field. If you're somebody who really loves neurology or MSK, you're an exercise or athlete, I think it's a great field for that too. If you're somebody who doesn't want to go into surgery, but doesn't only want to do clinic or inpatient and wants to do some procedures, learn ultrasound, be on the cutting edge technologies that are coming out, PM&R is that field to go to, especially for that artificial intelligence, prosthetics, amputations, stem cell therapy, regenerative therapy, all these different things. And then lastly, like if you want to be a mentor, a coach, someone who feels like they can put purpose into other people's lives just by giving them hope, I think, PM&R is the best field for that because you can really curate your own field. Like for me, I want to do regenerative medicine with ultrasound, with O&M, along with integrated and functional medicine. And I can kind of combine that into my own practice without feeling pigeonholed into one thing or the other, where certain specialties that may happen to you.
Right. That totally makes sense. So you can like have a broader aspect of everything. Well, I just want to thank you so much for your time. I really appreciate you getting, especially so last minute. We really,
No worries at all. I enjoy coming on here, Karen. Thank you.
yeah. So if you just want to tell them your Instagram and stuff like that, so people, if they have any other additional questions, they can just
Yeah, absolutely. So my Instagram is at Dr.Darsh, DOCTOR.DARSH. Go ahead, follow me there. I just got named top 50 people to follow on Instagram for doctors, so I guess that's cool. So definitely come DM me. I respond to everybody. For those of you guys who already DM me, you guys know that. I'm hope giving you guys value in some sort of way, but I really focus on perspective, lifestyle, medicine, books to read, podcasts to listen to. Got my own podcast out called Optimize Your Life. That's on Spotify and Apple. So if you're interested in becoming the best version of yourself, you can definitely subscribe to that. And I also just created a newsletter out where I'm actually got a draft up right now that I got to send out. So all these can be found in the link in my bio on my Instagram. It's under the link tree. You'll see a whole bunch of things. And I also do a mentoring or coaching program for pre-meds. So that's something that you're interested in. Just DM me. Just DM me anything. I'll respond. So
That's awesome. Again, thank you so much. And if you guys have questions or want to know more, just head over to his page and he can probably help you out. All right. Good night, guys. And we will see you guys next week. Bye.
see you.